Thank you everyone for joining the ACP webinar series. My name is Waleed Khalifa. I'm a medical oncology ST4, currently in Lancashire Teaching Hospital and due to rotate to the Christie next week. This month's webinar is going to be on small cell lung cancer. And I've got two fantastic speakers with me today that have taken time out of their very busy schedule to facilitate this teaching session. So my first speaker today is Professor Alastair Greystoke, who will be talking to us about the topic of systemic anti-cancer therapies today in the setting of small cell lung cancer. Professor Greystoke joined Newcastle University at the Northern Cancer Centre in 2014, and after 8 years he spent at the University of Manchester and at the Christie NHS Trust. He's been involved in the running of the Sir Bobby Robson Early Clinical Trials Centre at the Freeman Hospital in Newcastle, and has a special interest in the development of new anti-cancer drugs for patients affected by lung cancer. He's a member of the Lung Clinical Studies Group, Systemic Therapy Research for Non-Small Cell Lung Cancer in the Northeast. He's the subspecialty lead for lung cancer for the Northeast of England and the North Cumbria NIHR Clinical Research Network. And he also leads the pharmacodynamic biomarker team at the Northern Institute for Cancer Research at Newcastle University. My second speaker is Dr. Amin Ali. Dr. Ali is a consultant clinical oncologist who is based at the Rosemere Cancer Centre at Lancashire Teaching Hospital. He joined the Trust in April 2023, and he trained at the Christie Hospital in Manchester. He received a University of Manchester Award and Cancer Research UK grant in 2019, and is currently undergoing a lab-based PhD in prostate cancer. Dr. Amin Ali will be focusing on the radiotherapy aspects of small cell lung cancer. I'll now leave the floor to Professor Greystoke up in Newcastle. Professor Greystoke, please share your slides with us.
So there are my disclosures. My very first house job when I was working back in 2000 was in Edinburgh, and there I was treating small cell lung cancer as a house officer. And it's actually a very satisfying cancer to treat when you're a house officer because it's easy. You can get the sick patient like this who's presenting with nasty nodal disease causing SVC obstruction, and you can come in and you can very quickly give them chemotherapy as an urgency on the inpatient. And you can see that even within a couple of weeks that this is exactly the same patient. They had really quite marked nasty disease, and that was already responding on X-ray by 2 weeks later, and the patient was feeling better, and everyone feels better about themselves, and you feel like you've done a good thing. And it's not often in medical oncology where you get to see those dramatic responses day in, day out, and you can almost guarantee it with small cell. The problem, however, is that as a consultant or as a senior registrar, you often have to deal with the consequences, and actually treating small cell can be really hard. So this is just the lung windows of that patient when she had a response scan, and you can see that she had really quite pronounced emphysema and COPD. And unfortunately, you can see she had a prolonged inpatient stay in the grey before we even made the diagnosis. So she'd been in 2 months before we even got to that diagnosis. She then had 3 cycles of treatment with a scan showing a partial response halfway through, and then got admitted again between her 3rd and her 4th treatment with an infection, and then had progressive disease very shortly afterwards. And we moved to best supportive care because she wasn't fit for second-line treatment. The other thing to say about small cell is that, it does require very urgent treatment. So this is some work out of my PhD where we looked at circulating tumor cells using the cell search technology. And normally it's quite hard to find circulating tumor cells in patients with cancer. Prostate cancer, you're looking for about 5 CTCs in 10 mils of blood. But very early on, we were seeing like thousands and thousands of these, and you could even see in the top window where it says mitotic CTC, we could actually even see cancer cells reproducing in the patient's bloodstream, which is quite scary. And this paper suggested that there's the mean doubling time of small cell in terms of volume on the scan is only 50 days. And so that patient I showed earlier, where she'd been an inpatient for 2 months in the initial diagnosis stage, her cancer will have doubled in volume in that time. So it's a nasty, aggressive malignancy. So important questions for small cell lung cancer when I see them is, first off, am I the right person to be seeing them? Can it all be encompassed in the radiotherapy field? And we'll be hearing more about that shortly. So has a lung clinical oncologist looked at the pictures? And then you have to think carefully about the performance status, what it is now and what it was like, 2 months ago before they started to become unwell. And in particular, trying to make the decision, do you need to start treatment today, or do you have time to book them in a week on your chemotherapy unit, or can they even wait longer to potentially be worked up for curative treatment? So I'm not really going to talk about radiotherapy because I'm going to leave that to my esteemed colleague, but just to point out this data, which we may see later on from the CONVERT study, that if you do treat appropriate patients, about 25% of them may be cured, even with limited stage small cell lung cancer by appropriate treatment. But I'm going to concentrate on extensive stage today. And these are the ESMO guidelines, which you should at least be looking at and were published a couple of years ago. And I thought I'd just take you through them and show you what the evidence basis was, because sometimes it's not altogether clear. So you can see that on the left, it says, if the patients are fit and have no contraindication for immunotherapy, we should be giving them carbetoxide and immunotherapy, either with atezolizumab and durvalumab. If they do have contraindications, we just give them chemotherapy. And there it talks about a number of different partners, etoposide, topotecan, and irinotecan, which may come as a bit of a surprise to people. And if they're less fit, maybe using carboplatin and etoposide and gemcitabine, or gemcitabine as the partner. And then it talks about the role of consolidated radiotherapy if they're not having immunotherapy. And again, that might be something that may come up in questions when we should be using consolidated radiotherapy nowadays. And I'm not, again, going to talk about PCI because that's probably a whole talk in itself, and again, may come up in the discussions. So I guess the first question is, do we actually need to give platinum? So this is a meta-analysis that was done in 2000 of 19 different studies and showed an improvement in response rate of using platinum-based therapies. There's over 2,000 patients, and suggested about a 5% improvement in survival at 1 year if you do use platinum. But then another meta-analysis, in 2015, 32 studies, 6,000 patients, basically showed improved response rate, but no improvement in survival. But I think that ship has basically gone, and everyone pretty much nowadays feels that we should use platinum-based treatment. But the evidence actually is not that great. And then people, when I was training, used to spend a lot of time talking about whether we needed to give cisplatin or carboplatin. And again, there's a meta-analysis on the left. Sorry, a meta-analysis using individual patient data. There's only 4 studies. Some of them were very old, to the point where we were not even using the Calvert formula to dose carboplatin, so using milligrams per meter squared. But I think, trying to get your pointer between the blue and the yellow curves is very, very difficult. And there's been a number of real world studies. I've shown a Canadian one on the right that basically show very little difference between cisplatin and carboplatin. And certainly, I don't use that anymore, cisplatin anymore in extensive stage setting. And there's even good data in the limited stage setting that carboplatin is probably equivalent to cisplatin. So don't get yourself hung up on that. What about the partner? Do we need to use etoposide? Well, again, here's a big meta-analysis of some studies looking at etoposide versus other agents. And again, showed very little difference here comparing etoposide, for example, to irinotecan. Survival very similar, which is why irinotecan is in the ESMO guidelines. And in fact, etoposide causes a bit more myelotoxicity. Irinotecan causes a bit more GI toxicity, but either is very reasonable. And in Japan, they tend to use far more irinotecan than they do etoposide. So the partner may not matter. The next thing is certainly in Newcastle, when I was in Manchester, we used to try to give intravenous etoposide on days 1, 2, and 3, which is what was done in all the studies. I've moved to Newcastle, a smaller centre. We have capacity issues. So we only give intravenous etoposide on day 1, and we tend to give oral etoposide on days 2 and 3. Now, actually, I don't really like that. This is just showing a curve comparing the pharmacokinetics versus the age, and you can see this graph is all over the bloody place. And actually, the pharmacokinetics of oral etoposide can vary as much as 10% from patient to patient. Sorry, tenfold by patient to patient. So it's really not very predictable, but we have to bear in mind that we work in a cash-strapped health service. Certainly our waiting list to start treatment is routinely 3 weeks. And also, if you do it intravenously, you bring the patient back for another 2 days every 3 weeks. So although I don't like it, I do give oral etoposide routinely now in my practice. The other thing that we sometimes do, and I don't think it's done enough and wasn't actually mentioned in that guidelines, is in patients who have poor performance status, just giving single agent carboplatin. So this was quite an old study. You can see 2001 was published, and it was patients who were not fit. So either a KPES less than 50, so poor performance status 2, or a good performance status 2, but other poor prognostic factors. And they compared single agent carboplatin to CAV, which was one of the standard treatment options then, so triplet chemotherapy. And basically, you can see in this poor patient performance status population, there was actually no difference in overall survival between giving those two different chemotherapy regimens, although responses were higher in the CAV population. But in terms of survival, no difference. And so this is something that I commonly use in patients with poor performance status, particularly if they do have disturbed liver function, or if they've had a good, extensive disease burden and they're just sick because of cancer, trying to give them one cycle of carboplatin to get them a little bit better. So don't be shy about it. The other thing that very commonly comes along is patients come along and you finish the 4 cycles of chemotherapy and they're in a good response. And you say to them, look, you're in a good response, but I am worried it may be short-lived. So they say, well, what about just carrying on the chemotherapy, or what about maintenance chemotherapy? So again, this is a maintenance, it's a meta-analysis that showed no benefit of maintenance chemotherapy, and particularly not if you carry on the same chemotherapy. So if you just carry on giving carboplatin and etoposide, for example, or very similar things. There was some suggestion that if you switch your chemotherapy to a different one, there may be some benefit. But again, this is not something we do routinely, and there basically wasn't any significance. So maintenance chemotherapy is not a good idea and may just use up bone marrow reserve and for when you need to give them subsequent treatment. The real challenge is sometimes working out patients that we shouldn't treat. Unfortunately, this is data from National Lung Cancer Audit from 2014, but it's very similar now. So about half the patients who present with small cell will have poor performance status 2, 3, 4. And you can see on the right, this case series that if you treat patients with performance status 4 with small cell, unfortunately, the vast majority of them will be dead within 2-3 months. And even patients who have limited disease with poor performance status, relatively small numbers, but unfortunately life expectancy is poor. So we do need to be aware when you are treating patients with poor performance status that their prognosis is not good. They have poor performance status for a reason. And this was a really sobering national study that was done from Denmark, published about 20 odd years ago, very brave of them. So they took the 1,000 odd patients that they treated over a year and looked at how many died in the first cycle of treatment, and 12% died in the first cycle. And then they looked at the things that predicted whether patients were more likely to die either of a toxic death, so from treatment, or of a non-toxic death, presumably due to progressive disease. And you can see there that they found 3 common factors: performance status 3 or 4, a high LDH, and older age. And if you had all 4 of those factors, if you had the top score, then your chance of dying in the first cycle of treatment was 7 times higher than the reference population. So we do just need to be aware that patients can and do die following the first cycle of treatment. Now, some people get very worried about that. We all get, have our 30-day mortality meetings and stuff like that. But equally, if some of your patients with small cell are not dying in the first cycle, you may not be treating enough. So you can rescue some of these patients. They are sick. So it's trying to choose the right patients, but accepting that some patients will not make it through cycle 1. Setting expectations. So I showed a slide in 2018 that basically showed that the original carboplatin etoposide paper was in 2000 and it was in 1980 something, and there was something like 800 studies following that were all pretty much all negative, and nothing changed first-line treatment until these 2 studies came along, which were adding immunotherapy alongside first-line chemotherapy. So the Iron Power 133 study and the Caspian study, you can see they got into good journals, New England Journal of Medicine and Lancet, suggesting that these were leading to a major advance in the field. Now, at this time, people were giving single agent, so the Americans were giving single agent immunotherapy in the 3rd-line setting, which when you give it by itself has a response rate of about 5 or 10%. But these studies, as we'll see, gave it alongside chemotherapy. And I'm going to concentrate on Iron Power 133 because that is the one that we have access to in the NHS. We have access to atezolizumab. AstraZeneca never looked to get access to durvalumab in the NHS, but the data is almost identical. You can pretty much overlay the two study designs and the final results. So IMpower 133 was a relatively moderate-sized phase 3, so it had 400 patients. Took patients that had extensive stage small cell lung cancer, and they had to be fit, and they were allowed to go on if they had asymptomatic treated brain metastasis. So whether that's the right thing, that wouldn't be what we normally do in our patient population, but 13% of the patients did have brain metastasis. And they were randomized to either carboplatin etoposide for 4 cycles, with or without atezolizumab given intravenously, and then that carried on until progression. So there was no 2-year stopping rule like there is in the non-small cell population. So in fact, in the NHS nowadays, you can carry on your immunotherapy for as long as the patient is benefiting. And I've got a number of patients that are now on 3 or 4 years of treatment. Numbers are smaller. Again, this is not non-small cell, so here you see PFS, very little change in PFS, so the curves pretty much run together during chemotherapy. There was no real change in performance status, but what you can see, and the reason why we give it, is if you look at the 1-year stage, the patients who were progression-free, if you just give chemotherapy, only 5% of patients were progression-free and alive at that point, and you about double that with your immunotherapy, but that's still only 12%, so this is not earth-shattering. But there was an improvement in overall survival, so about a median increase in overall survival of about 2 months. And again, if you look at some important key landmarks for patient, you can see a 14% increase at 12 months and a 13% increase at 18 months. It does look like the lines are covering together, but there haven't been any further data cuts. So there's lots of censoring around this. So we don't really know how these patients do in the long term. But that's the reason why we give this treatment to patients. Is particularly for that survival benefit of 2 months, which doesn't sound like much, but if you've got an estimated survival of 10 months, is important. Quality of life and safety is important. So you can see here the quality of life on that study goes up in both arms. So both the blue arm with atezolizumab and the grey arm with placebo over time. When you give the chemotherapy, patients feel better. And then over time, it's maintained in the patients on maintenance atezolizumab because hopefully they're staying in response, and starts to drop in the patients on placebo as they relapse. On the top right, I've looked at delivery, and it's very important that giving the immunotherapy doesn't impact on your chemotherapy delivery. And you can see the numbers who had to discontinue chemotherapy were very small in the acute phase, so it was only a couple of percent. And the numbers who discontinued immunotherapy were only about 4 or 5%, both in the acute and maintenance stage. And then in the bottom, just looking at toxicity, so looking at immune-related adverse events, we're not very good at judging these because you see in placebo, investigators were saying about 15% of patients, that's the blue, were having potential immune-related adverse events, but that was increased by about 10% in patients who had immunotherapy. And you can see the rates of interruption were relatively low, about 10% of patients requiring a dose interruption for an immune-related adverse event, and treatment withdrawal due to toxicity pretty rare, around about 3 or 4%. Probably in the community, we do see more of this, but we can deliver this treatment to our fit patients. Now, these are expensive drugs, and they're only giving us 2 months. Can we predict the patients who are likely to benefit? So people have looked at PDL1, and basically there's no benefit. If you look down at the bottom, you've got various things showing looking at PDL1 expression of 1%, 5%, and basically showing that it doesn't help predict which patients do benefit. We've also seen data looking at tumor mutational burden and blood tumor mutational burden. And again, it does not predict which patients are likely to benefit from treatment with immunotherapy. The emerging area, and this will probably be coming forward in the next 5 to 10 years, is it appears that there are 4 different subtypes of small cell, and you can split them out, and they're called after the one of the IHC stains that helps you predict them. So there's the N group, the A group, the I group, which stands for inflamed, and the P group. What I wanted to, so if you look in the bottom right, so the NMF3, so this is an inflamed group. They've got very low tumor macrophages, and if you look at the hazard ratio there, these are the patients that particularly benefit from having the immunotherapy, but unfortunately, it's only about 14% of the population. And then if you look at the top right, that's 22% of the population, but you can see the hazard ratio there in brown is basically spot on 1. So this is also an inflamed type, but they've got lots of tumor-associated macrophages. It's a very immune suppressive environment. They don't seem to benefit from immunotherapy. And then the two on the left are sort of immune deserts, so they may get a little bit of benefit from immunotherapy. So increasingly, this is starting to be used in trials to try to work out which patients may benefit from immunotherapy or not. But this is, area of research. At the present, we just give it to everyone and hope that they might be in that 14% and that they might do well. Next, I'm just going to come on to second line treatment. So what does the ESMO guidelines say? Well, they say if you're fit, so if they say it's more than 3 months that you can re-challenge with platinum etoposide, but you can also use either oral or IV topotecan or CAV, which I talked about before. If they're resistant, so relapse within 3 months, you can use either of these regimens. And if they're fit, you can use potentially use lurbinectedin, which is a new cytotoxic that's coming through, but it's not yet available in the UK through the NHS. So again, important questions. What's their performance status? Do you have a clinical trial? What are you trying to palliate? Should you just be using some radiotherapy? How did the patient go with their chemotherapy last time? Did they respond? Did they tolerate it? Did they have good disease-free interval? But what's particularly important here is what does the patient actually want to do, and what are they expecting from your treatment? This was a large retrospective European data series led actually from Rafael Califano at the Christie, where they looked at 112 patients who had platinum sensitive disease and where they had re-challenge. And you can see the response rate is on the order of 40-odd%. Progression-free survival was about 5 months. And in fact, it didn't matter whether the relapse-free interval was 3 months, 6 months, or longer. They all seem to derive equivalent benefits. So I would say very much if your patient's got more than 3 months benefit from the last chemotherapy, should be what we should be considering. What about topotecan? Well, this is a very old study that was led by Mary O'Brien and published in 2006. And this was patients who were second line, not thought to be fit for intravenous chemotherapy. And they were randomized either to oral topotecan, as we give it now, or best supportive care. And there was a survival benefit associated with topotecan. And as I'll show you, there was also a quality of life benefit, but it's not the easiest treatment. And they did have 4% toxic deaths in this treatment. So you can see there the improvement in quality of life in these patients. So that's why we give it. I'm not going to talk about that for purposes of time. So this is my table that I sort of use for trainees. And what can we expect for chemotherapy? So first line carboplatin etoposide, you can see that you get high response rates, but 12-month survival is probably only about 30%. There's your re-challenge data. And again, your 6-month survival and your 12-month survival is about the same because these patients are survivors. Topotecan in the refractory setting is pretty poor, and we should always be looking at trials. It's a bit better if your patient is platinum sensitive, but in that situation, I'd be tending to be using re-challenge anyway. So we definitely need better treatments in the second line setting, but unfortunately, topotecan's been difficult to beat. Just to show you lurbinectedin, which is approved in Switzerland, and so just in case we do get it in Europe anytime soon. So this is a novel cytotoxic, and this was a subgroup of one of the studies where they compared lurbinectedin to topotecan. So this is just comparing 2 cohorts. This is not a direct study, but you can see that they sort of matched patients and they saw higher response rates with lurbinectedin than with topotecan. Similar lengths of control, progression-free survival, but improved overall survival. And certainly lurbinectedin is much less toxic than topotecan. So you can see that bottom right, less dose reductions, less dose discontinuations due to toxicity, less need for transfusions, and less admissions to hospital with treatment-related events. So probably, may be beneficial to patients, but not yet available to us. And I hate to give caveats, but for some reason, when they went into their randomized phase 3, they decided to combine it with doxorubicin. So they did a head-to-head study, second-line patients with small cell, performance status less than 2, compared to topotecan or CAV, investigator's choice. And this was a completely negative study comparing lurbinectedin combined with doxorubicin against investigators' choice. So that was a real slap in the face. We weren't expecting that at all. Lastly, for the last 5 minutes, I'm just going to talk on what's new in terms of third line treatment, because this is going to come through probably this year. And this is the issue of BiTEs, or T-cell engagers. So T-cell engagers are bispecific antibodies that with one arm of the antibody latch onto CD3, so they latch onto your T-cell, and with the other arm will bind onto a tumor antigen. And the ones that we're seeing for small cell against the protein called DLL3. Now that's extensively expressed on nearly every single small cell, particularly in the second or third line setting. It gets upregulated as small cell becomes chemotherapy resistant, and it's not very commonly expressed on normal tissue. So this is a very good target. And the idea is that you latch your T cell, you sort of pull it together like a molecular glue onto your tumor cell, and that then leads to T cell proliferation, T cell attack, and tumor cell apoptosis. And in the bottom right, I've shown the first phase 1 data report, which shows that even at low doses, we started to see very nice efficacy. And there was a randomized phase 2 that was recently published in the New England Journal just at the end of last year, where they looked at 2 different doses of a drug, which now has a name. It originally was called Amgen 747. It's now called tarlatamab. They looked at 2 different doses. They saw a response rate of about 40%, but some of those responses were very long lasting. So it's very immature data, but they haven't even reached median survival yet. And you can see that a number of patients here, if you look at the sort of progression-free, or the median progression-free survivals, only about 4 or 5 months, there is a significant tail on the curve. So the number of patients who now have responses 1 year, 2 year, even longer. So suggesting that this potential immune effect may lead to long-lasting efficacy. The problem is that because you're leading to activation of T cells, you're going to start to see some of the toxicities that we see with CAR T cells. So cytokine release syndrome is when you latch your T cell onto your small cell. It releases all the cytokines that it wants to release to kill your cells. So you get high levels of interleukin 6, CRP. That leads to a sort of iatrogenic shock, where you get vascular leak, hypertension, fevers, pyrexia. So there's very good guidance out there already for CAR T therapies, and your hematologists are well used to this. But I've started giving these to third line small cell patients, and it's not the easiest treatment in the world. You need to know what you're doing. You need to have access to tocilizumab, which is an anti-IL-6 antibody if you do see it, and you need to have an ITU that's prepared to help you out. The other toxicity that you can see is what's called ICANS, which is T-cell associated neurotoxicity. Nobody's quite sure how this occurs. Again, it's probably due to cytokine release, vessel permeability, and then T cells going into the brain. So it happens a bit later than cytokine release syndrome. But basically, your patient becomes confused a few days afterwards and can even go into seizures. And it's not much fun. But again, there's very good management. The good news is that these tend to be first dose effects. So you can see here in the top, that's a lower dose, the 10 milligrams, which is coming forward. And most of the patients, if they are going to get cytokine release syndrome, they get it on the first couple of doses that are given weekly. Levels of grade 3 CRS, which is when you're going to be calling your intensive care person with the lower dose, were only about 1 or 2%. So hopefully this treatment should be deliverable. Just a final note of caution, because this is small cell, I can't end on a high note. So this was an antibody drug conjugate against DLL3, same thing called Rova-T. That was the phase 2 data in third line in a study called Trinity that showed a very similar response rate to what I showed you with tarlatamab, but that then failed in its randomized phase 3 comparing to topotecan, and that drug got killed about 5 or 6 years ago. So that's a real whistle-stop tool, but hopefully showed you that small cell is challenging but very interesting. The biology is complicated. We don't really understand. It's difficult giving it to the population because they often have poor performance status, multiple comorbidities, and often, unfortunately, from the lowest socioeconomic quintiles. You do need to set up pathways for rapid referral. So we have a rapid referral pathway for small cell where the pathologists tell us if they see a small cell so we can scoop in and treat them. There are a number of therapies coming forward with some questions and challenges. I'm sure we'll be hearing how you best integrate radiotherapy going forward, and we can maybe talk about that But some of the new toxicities, not only checkpoint inhibitor toxicities, but as we start to use these T-cell engagers, things like cytokine release syndrome will be a challenge for us all. So with that, I'd like to stop. Hopefully I've kept reasonably to time, and happy to answer some questions.
Absolutely great. Thank you very much for giving us that talk today. It was very enlightening. I don't think we have many questions, actually. We don't have any questions that have come through from the webinar chat. So perhaps you've answered everybody's questions tonight. I have a quick question about patients who have a performance status that is where they're frail and you'd like to give them some treatment, but you're going to use single agent platinum with carboplatin. And I think you've mentioned in your talk that response rates with carboplatin etoposide are kind of in the range of 48 to 78%. If you're using single agent, what do you expect the response rates to go down by? And what about kind of like 1 year survival rates?
Yeah, so the response rate is lower. I normally talk about a 40% response rate, maybe 40-50% response rate to single agent carboplatin. It's difficult to correlate to say what the 1 year survival is, because if they're that frail, these patients have a poor prognosis. So very few of them will live, I would say under 6 months. So I normally quote for fit small cell, I would normally quote 10 months to a year. Based on the Iron Power 133 data. In a patient where I'm offering them single agent carboplatin, I'd probably be talking about 3 to 6 months, because I'm offering it to them for a reason. They've got nasty disease. Yes, oral topotecan. Yes, good question, Adam.
I'll just mention that question just so that the
go read it out.
But it says, anyone able to access oral topotecan? It's not been able to get it for months. Thoughts on IV topotecan as an alternative, between brackets, very toxic.
Yeah. So no, that's a very good point. So there has been a shortage of oral topotecan, and we haven't been able to get hold of it. Now, theoretically, actually, NICE has said that you should only be giving topotecan if they're not suitable for CAV. Now, actually, we've always tended to give topotecan anyway, because CAV is not particularly nice either. So I would tend to give CAV, so vincristine, doxorubicin, and cyclophosphamide over IV topotecan. IV topotecan is toxic, and it's 5 days intravenous. So in terms of capacity, your day unit is going to absolutely hate it. So I guess that's my question about CAV versus topotecan. So I don't like either of them, quite frankly. We tended to use oral topotecan, at least in Newcastle, because of the oral nature of giving it to patients. But just because it's oral, it is toxic. If you look at the O'Brien data, which is the doses that we use for oral topotecan, 2.3 milligrams per meter squared, day 1 to 5. It's not nice stuff. And so what I've sometimes done, again, in patients where you're not entirely sure, is you give them, and when we did have access to oral topotecan, used to give them days 1 to 3 at the same dose, just to see how they got along. But second line treatment for small cell CAV topotecan has been rubbish. But the problem is all the trials before. So when we compared, Rover 2T, that exciting new drug, to topotecan was just as good. We had lurbinectedin, and we thought that was an exciting new, less toxic drug. I don't know why the company decided to add it into doxorubicin. Didn't make any sense to me. But again, didn't beat topotecan. So if topotecan's a really low bar, well, that was topotecan or CAV, investigator choice. We haven't yet beaten it. So I'm really hoping. There are now studies looking at tarlatamab versus topotecan. I think the Christie are running one, so our randomized phase 3s now looking at this, and I'm really hoping that something now finally will beat topotecan, because it's a horrible drug. Basically, you always think that the patient shrinks almost as quickly as the cancer does. Unfortunately, I don't like it very much, as you may gather, although I give it.
That's great. I don't think any more questions have actually come through. Thank you very much for your time this evening, and thank you for your slides too. That was fantastic. We'll move on to the next talk for tonight by Dr. Amin Ali, who will be talking to us about the radiotherapy component of small cell lung cancer management.
Well, thank you very much to the committee for inviting me to give this talk to a very enthusiastic crowd. at this hour of the day. So my task is to talk about the role of radiotherapy in small cell lung cancer, and hopefully this will complement what Professor Greystoke just spoke about just now. So first of all, basically what I'm trying to do today, my aim is to give it into four main areas of just a little bit about the history of radiotherapy in small cell, talk about the role of radiotherapy in the concurrent consolidation, and also a little bit about the PCI role of in small cell lung cancer. So just a little bit background about radiotherapy by itself. So we are treating radiotherapy in patients in the role of about 1,000 millisieverts for every session of radiotherapy. In comparison to what a CT scanner is, it's about 100 to 200 times of a CT scan, and the patient's getting probably about between 10 to 30 sessions of radiotherapy. So just in perspective, radiotherapy, there's a lot of dose of radiation that a patient receives for treatment of cancer in general. And the reason why it's important is later on, I'll be discussing about a little bit more about how the progression of radiotherapy has gone by throughout the years. So this is an algorithm that I use seeing patients in my clinic. Basically what Professor Greystoke was showing the ESMO guidelines, showing the role of radiotherapy where we use it in limited stage, in concurrent, sequential, and also in the extensive stage setting here. And I'll talk a little bit more in detail with regards to the evidence for the role of radiotherapy here. So just a little bit of background. For small cell lung cancer, usually we listen to people talking about what is limited and extensive stage. Going back basically means that if you can fit it within a radiotherapy field, that is what is considered as limited stage. And if you can't fit it in a radiation field, that's extensive. And basically boils down into stage 1 to stage 3 is limited stage. Stage 4 is actually extensive stage. However, if there's a patient with a stage 4 disease with pleural metastases or pleural involvement, speak to the radiation oncologist or clinical oncologist to see if there's a possibility of offering radiotherapy to these patients. So this is a little bit about radiotherapy throughout the years since the early 1900s, where radiotherapy first started. This diagram basically shows the differences throughout the years of when we started with conventional radiotherapy to 2D images and then 3D and MRT. Basically, it's showing how, if we think about it as a sculpture, how fine the sculpture is with the current techniques of radiotherapy. And basically, this is showing that we could treat where the area that we want to treat very, very precisely, and we could avoid the organs at risk. So basically less toxicity with the recent or with the more advanced radiotherapy technique. And this comes into play of thinking about where radiotherapy was before when we treated small cell lung cancer with regards to the toxicity and what we can do now as well. So just a bit about the current state of concurrent chemoradiotherapy, which my focus would be in this stage of patients, where this is the landmark paper in 1999 by Turisi, basically showing that twice daily radiotherapy of a dose of 45 rays and 30 fractions was doing much better compared to those that get giving one dose of radiotherapy per day. And it shows a 4-month overall survival, and this was a significant study. And as highlighted by Professor Greystoke earlier on, with regards to the CONVERT study that was done in Manchester by Professor Faberfin in 2017, it shows that the BD dosing of the 45 ray and 30 fraction twice daily versus a daily 66 ray and 33 fractions, there were no significant difference despite the numerical differences. And this was also updated last week in one of the conferences as well, with regard to the long-term outcomes, and showing that there are no significant difference between the two. If basically the center can't do a twice daily fractionation, possibly the once daily fractionation is equivalent because of this the way how the study was run. So this is a busy slide, but what I like to highlight within these 4 lines is basically showing this meta-analysis, where you could see at the top line here is showing that patients that are getting early or shorter radiotherapy, which is mostly the twice daily dose, as well as being very compliant to the chemotherapy, they do best with regards to survival compared to patients that are getting longer radiotherapy, or if the radiotherapy is given sequential, they lose. There's this 5% difference in about 3 years. But what's more striking in this diagram here that I'd like to highlight is these two curves at the bottom here. And the main difference between these two curves at the bottom is talking about the compliance to chemotherapy. Going back to what was highlighted in the previous talk is that this is a very sensitive type of tumor where compliance to chemotherapy is very, very important. So despite whatever radiotherapy that we're giving, if the patient is not compliant or we can't fit the chemotherapy per schedule, it can be detrimental to the patient as well. So just as a summary part of this is that if we're seeing patients in the limited stage, speak to the clinical oncologist or radiation oncologist early on so that we could start treatment for concurrent chemoradiotherapy early, either in cycle 1 or cycle 2. If the patients are not fit, we go for sequential. And then the compliance of chemotherapy is really, really important in patients with small cell lung cancer. So moving on, talking a little bit about the consolidation part of chemoradiotherapy, where we usually use this consolidation in the extensive stage small cell lung cancer, where this study, the landmark study that was in 2015, showed that if patients had thoracic radiotherapy because of disease in the thorax, there is improvement in overall survival at 2 years, where patients, it's not great. However, patients receiving only chemotherapy had a 3% survival rate at 2 years, and there was an increase to about 13%, which is a 10% increase in overall survival. And this is quite a big number in oncology world, where there's a big difference at 2 years. At that point of time, there was also meta-analysis using this study as well as another study showing, in keeping with the overall survival and progression-free survival advantage of giving thoracic radiotherapy in extensive stage lung cancer. Going back to my few slides before, this is where the history part is quite important, as this information was only best at 2015, and the type of radiation that was given at this time as well needs to come into play as well when we are comparing to the kind of like the studies, like the iron power study as well. So just specifically in this specific study, what they looked into by giving this consolidation, so this is a type where in the extensive stage small cell lung cancer, is that patients without any residual disease after receiving chemotherapy, basically having complete response, there was not much advantage, or there was no differences in the overall survival. The numbers, as you can see here, were very low. However, patients, which were the majority of patients, where they have partial response to treatment and we have thoracic disease still present, there is an improvement in overall survival for patients receiving thoracic radiotherapy. And this is where the data lies, where we would offer consolidative radiotherapy to patients with extensive stage lung cancer. So this is going back to the paper of the chemoimmunotherapy, just to highlight the differences of this. If we're talking about the 12 months overall survival, half of the patients going for the chemoimmunotherapy combination was about 50% at 12 months, and about 40% or 39% with just the chemotherapy alone. What I'm trying to show here is, with the data that we have in 2015, where cross-comparison study is not great to do. However, just to highlight differences in the study in 2021 and 2015, with the same type of chemotherapy being given, there's a very 28% here versus a 39%. So it shows that probably with the type of care that's been received, and also the modern type of medication that's being given at this time, it also improves in survival. So just to summarize, consolidation radiotherapy reduces intrathoracic progression, and the overall survival has shown to be improved at 2 years compared, and no differences at 1 year. And the last part of the talk is about the prophylactic cranial radiation. So just before I go into it, prophylactic cranial radiation is just a fancy name of whole brain radiotherapy. It's exactly the same technique being used. It's just a different name being given because we're treating the brain without the disease being there. So prophylactic, as everybody knows, means prevention. However, when we're talking about this prevention, we are assuming that patients do not have any brain metastasis to begin with. And this is a very big assumption in the data that I'll be showing, because most of the studies is actually done based on just clinical symptoms, and there was no, the imaging of the brain was not necessary, it was not compulsory for most of the trials for this type of data that I'm showing. So the role of PCI is in both limited stage and also extensive stage disease, as you can see by the arrows here. And in the limited stage disease, basically the incidence of brain metastases nearly halves when you give PCI. And also the overall survival, there's a 5% increase in overall survival at 3 years. And this is also true in the extensive stage as well, where PCI reduces the risk of brain metastasis by more than half of it, as well as the increase in overall survival at 1 year also doubles as well. So why fix it when it's not even broken? So with the role of PCI now showing that there is improvement in overall survival, why are we still looking into trying to get better treatment for patients? Because as I told earlier, that we are assuming that patients with PCI do not have brain metastasis up front. However, it wasn't compulsory for any brain imaging. So a meta-analysis also looked into this, basically showing that what they did, they showed that there was survival benefit. However, because of the lacking of the radiological confirmation of brain metastases, the survival benefit might be due to actually being therapeutic rather than prophylactic. And because of this, there are currently ongoing trials trying to understand the role of either patients going for PCI or having MRI surveillance. And if patients develop brain mets on the surveillance, then the offer of having whole brain radiotherapy is being given at that point. So there are 2 trials being run concurrently now in different areas, where the primer lung study is currently open in the UK, and Maverick is a US-based study looking at this specific question of the role of MRI surveillance versus PCI. So just before I end, just a few questions within the radiotherapy field in small cell lung cancer is to talk about the role of dose escalation in both limited stage and extensive stage small cell lung cancer. The relevance of PCI, can we actually go away with PCI and do a little bit more of MRI surveillance? And also the role of consolidation radiotherapy now in extensive stage small cell lung cancer, especially in the era of immunotherapy as well. And what's the risk for pneumonitis, as we know that increase in the use of immunotherapy increases the risk of pneumonitis. Radiation to the lung can also increase that as well. So this is just to highlight kind of like the current studies that are ongoing, which I won't go into a little bit more detail, but basically what I'm trying to show here is that there are a lot of active studies trying to answer the questions of the role of radiotherapy in each of these sessions here as well. So with that, I'd like to thank you, and if there's any questions, happy to take them.
That's great. Thank you very much for delivering this talk for us today. I suppose I had one question with regards to how soon we should start sequential radiotherapy. So once your patient has finished chemotherapy, how quickly should you introduce radiotherapy so that you can try and get as much benefit from it?
So the fact that patients are getting sequential radiotherapy means they're not fit to start off with. So usually what I'll try to do is within 3 to 4 weeks after therapy cycle, I'll try to get in the radiation.
Yeah. So within the month, really.
Yeah.
I've got a question as well, if that's okay.
Yeah.
So so IMPOWER 133, you weren't allowed to give thoracic radiotherapy. and the ESMO guidelines don't include it. Do you give it at all in extensive stage? Do you give it to patients who have bulky nodal disease? Do you give it when they progress in the nose, you know, and then carry on immunotherapy? These are things we come across day in, day out now.
Yeah, exactly. And I'm getting some referrals as well from my medical oncology colleagues where while patients on atezo, it's been stable disease, or if it's been progressing slightly further, then we might think about giving radiotherapy, but the data is not there to suggest that we can give it at this point of time because the risk of pneumonitis is still there. So I tend not to give it unless there is a very clear progression where we need to stop the treatment at that point, rather than if the patient is just going to continue on immunotherapy.
Yeah. You know, I think it's challenging because there have been trials that show it's safe to give immunotherapy alongside radiotherapy. Obviously, we've just seen Pacific 2, which didn't show benefit, but at least, you know, that's giving it alongside concurrent for non-small cell. Yeah, I struggle with. We have had some patients who've done quite well with that strategy. Actually, have just progressed on atezolizumab in the mediastinum, and where we've been able to give radiotherapy and have been able to carry on the immunotherapy, and we've got away with it. But yeah, it's always a bit of concern, isn't it, about pneumonitis and what happens.
Definitely.
That's fine. Well, thank you very much, both of my speakers tonight, for giving us fantastic talks on small cell lung cancer. Very much appreciated. Thank you for squeezing us into your very, very busy schedules.